First of all, thanks for the invitation to come and talk with you, and really want to highlight the importance of this forum, and you'll see why in terms of how it fits into some of the things I've been working on for the last few years. I'm supposed to have this disclosure slide. So, for the last 3 years, I've been working on this prioritized research agenda, and there's several people in the room who served as experts on this panel. We started out with about 700 people, different stakeholders, providing us input to develop some aspirational goals that would eventually reduce suicide. That was the whole point of this. And I'd agree with Dr. Schiff. We needed to be impatient. We've been looking at these numbers for decades, and it was time to try to do something about it. So we set this goal. What would it take to reduce the suicides by 20% in terms of numbers? And of course, all of us understand how long it takes to do research. But we felt like if we pushed ourselves in that direction, maybe we'd actually find something that looked tractable, something that we should be able to do. But to do that, if we stood back and said, okay, homicides have gone down, motor vehicle accidents have gone down. We know those are really well mapped, well characterized, well understood. What do we know about suicides, particularly among youth, which is what I'll focus on here? And as we walk through some of these issues, we started identifying some gaps in data, but we also recognized new data sets that we hadn't really used either. So I'm going to walk through some examples where I think we have opportunities to put that together. The way the research is organized, or the research gaps, are just key questions like, what causes suicide? How do you detect risk? What are adequate interventions? What are reasonable services? And also, what's some upstream prevention that could work? So for all of those, we're looking at short-term and long-term research objectives, as well as what we think we know about this and what the research gaps are. So today I'll just go over what is available right now. Some recently studied research, or recently funded research, I'm sorry. How we could look at the state vital statistics. Some Garrett Lee Smith, another SAMHSA evaluation, which I think is really hopeful. Some examples of measures for individuals that are system relevant that I think we need to build some more. And then just, give you a flavor of some big data issues. And we won't have time to get into the ethics of some of these issues, but that might be something we want to have another panel on, I think, because those are some real sticky ones. So just to give you, if you're not familiar with the suicide statistics, the 2012 data was recently released by NCHS. In the suicide field, we're always frustrated because it's been like 3 years of a lag because all the states have to report their data to NCHS. It's all clean. And the good news about that is we're very confident in this data. It's very reliable. States know what's there. But to do an intervention and then to have to wait that many years to figure out if something worked is really frustrating. And I think that's been something that's frankly depressed the suicide prevention field. It's just been really hard to do. It's also a relatively low base rate. We're talking about a rate that's like 12 per 100,000. So if you're building an intervention where you're trying to detect a change in a suicide death, it's very difficult to do. Just to give you a sense of some of the numbers and what this looks like. The CDC has this online. You can even download an app. You could be looking at it right now in this room to see what the statistics are through this online system called Whiskers. And you can drill down to state level and get some general demographics in terms of gender, age, race, ethnicity. They have also now included injury morbidity. So I'm going to interchange suicide attempts with morbidity here. And that's developed through a hospital emergency survey where people go through the medical records to look for attempts. And that's actually broken out by age groups as well. That's number of visits. That wouldn't be individual repeated visits in a hospital, but it's a sense of rates there. The National Violent Death Reporting System, which some of you might be familiar with, has recently expanded. That's an opportunity for state health departments to actually put a lot of data together around a death. Not quite like a psychological autopsy study where you do a lot of in-depth interviews, but it does give you the opportunity to link to, was this person experiencing stressors? The police records are available in this. Sometimes hospital records are linked. The coding sets for the MVDRS are very, very long. And there is a lot of rich data there. There's a listserv for the American Association of Suicide that's going right now talking about occupations. What can we learn from the MVDRS if there's certain occupations that have higher levels? And so you've got NIOSH interested in this, you've got MVDRS states looking at this. So I think people are finally figuring out there's some ways to drill down on this, and with that expansion, it's been 16 states, it'll be up to 32 states soon. So these are the national statistics, and you can look at it over time with suicide being relatively steady. It's kind of bizarre if you sit and think about suicide rates every year. Why would they be so consistent? You know, it seems like such an individual choice or a confluence of factors. And what's disturbing, we don't have the 2012 piece at the end of here. Alex Crosby sent me his slides that he put together last week. But 2012 is showing an uptick. And we're hoping that 2012 might show less of an effect of the recession. We kind of felt like some of those upticks in 2008, 2009 might reflect that. But this is troublesome. If we look at it for youth, 15 to 19, again, we had some success, you know, in the early 2000s, but there's still this little uptick. If you want to think about leading causes of death, and you might have heard about suicides for youth presented in this way, it sounds pretty dramatic, the second leading cause of death. And part of this is because young people don't die from other things. So, for example, in the 10 to 24 category here, that is 300 deaths in 1 year. So even though it's the third cause of death there, that's a relatively small number nationally. If we talk about the 15 to 29 groups, the 15 to 19 is 1,700 youth who died by suicide. For the 20 to 29, that's about 6,000. If we put these two together, we're approximating about half of the suicides in the US. And this middle age group is the group that's starting to show the biggest increases over time. So even though this is youth focused, we have even fewer clues as to what some of the risk factors are for middle-aged adults. I think we've been studying the youth ones a little bit better. So once we get through the youth stuff, we need to focus on the middle-aged ones. Now, the morbidity part of suicide can be characterized by, if you're at CDC, you talk about self-inflicted injury. If you're at NIMH, you talk about attempted suicide. Or you might talk about self-harm. Or if you're in Europe, you might talk about self-harm generally, with or without intent to die. That might all sound confusing, but we do have ways of characterizing this. So depending on, you know, what you're looking at, the costs for either self-harm or some intent to die, you know, it still is expensive. And here you can see the gender difference where you have many more females attempting than males in those kind of young adult teen years, but then actually evens out over time. The youth risk behavior survey has been mentioned before, and this is something that school districts and states have access to. This is pretty remarkable, and in terms of how we think about messaging this, if you're saying, you know, 20 to 25% of youth think about suicide, this is seriously considered suicide. You know, 1 in 5 kids have thought about that in the last 12 months. What does that mean? And again, what is preventing kids from acting on that? We just don't have a really good sense of why there's some kids who think about it and nothing happens, and some kids think about it and do something. When we have this gradient usually that we assume has meaning. We assume you have to think about suicide, then you would plan an act, you probably would act, and some of the more severe attempts require medical care. So we often think of this continuum, but we are aware there's surveys showing people will just seriously attempt without even thinking about it. Or they'll say, I thought about it for less than 5 seconds, I just did it. And this is where the substance abuse piece could play in. So even though we talk about this gradient, we really need some more longitudinal, kind of phenomenological data, I think, to understand some of these attempts. So I think you all know about the YRBS, what's available, anonymous. But it still gives you a snapshot. And we often encourage researchers to think about the items used in YRBS if you wanted to crosswalk and compare rates. So here's one example of an initiative that was considering those high-risk youth who had received medical care. And this is a study that a number of folks are involved with in the room that was recently funded. It's called ED STARS. And the rationale for this is using some of the HCUP data to look at how many visits are there. You've got a lot of visits by teens. A lot of them have psychiatric concerns. The coding for those with intentional self-harm, 128,000 across the U.S. What to do with those kids? If you've dealt with kids who have attempted suicide, as soon as they're in the emergency room, they say, well, that really wasn't a suicide attempt, or I didn't really mean it. And as a clinician, you're really faced with some huge challenges in terms of what to do, what's the best approach, who really is at more risk, who should be hospitalized. Given the challenges and the costs and the limited number of beds, how do you make these decisions? So that's what this initiative will be about. And there will be some efforts to try some new approaches. One is this computerized adaptive screen that Robert Gibbons has used. Hendricks has been involved in some of that work. And then this implicit association task, which comes from social psychology, that Matt Nock has adapted for suicide. Basically, your reaction time to words related to suicide and so on. So those will be used in this effort, as well as looking at medical record data, interviews, and so on. So that's some interesting individual level data that could be developed for this. So let's move back to suicide deaths. What could we do about this? This is an example of Utah kind of taking advantage of their one central medical examiner. So in suicide, I guess you'd say we have the advantage of having a very discrete event. We know suicides are probably undercounted. If we were in the UK, we would probably include the undetermined deaths with the suicide. Here we just focus on the suicide deaths. What Utah did, and this was Michelle Moskos, was looking at looking back at the youth suicides there, and started to look at within what agencies were these kids accessing before they died. And it turned out that 63% had had some contact with the juvenile justice system. And from the mental health perspective, that was like, oh, of course, that would be a place to find these very high-risk youth, but that doesn't often cross the mental health purview. I mean, most of us know it's there, but to really think about how to reach those youth hadn't really been done. So the folks working on this project decided there should be some ways to do some intervention. So screening was implemented for the kids going through the court system, and then some interventions. And this was a pilot study just to get things rolling. It looked like it did pretty well. The families who had the intervention, this was almost like a, not multi-systemic family piece, but really intensive help for these families. 80 to 100 hours of treatment. It looked like things were working, and then the funding was dropped. So these promising efforts were then brought to the Garrett Lee Smith program, which SAMHSA supports. And to quickly summarize where that's been, with another group that's been evaluating the Garrett Lee Smith efforts, most of the Garrett Lee Smith projects are pointed to SAMHSA's Registry of Effective Practices, or best practices. And many of those are gatekeeper programs trying to train teachers, people in the community, if somebody a youth is suicidal, how to refer them. So a lot of this is kind of a reflection of how well some of this training of providers has worked and what happened. So this is from that report to Congress, and they're working on some papers right now. I understand they've been submitted. But the bottom line is, for the Garrett Lee Smith counties that were exposed to what you would consider adequate training, the suicide rate actually went down. If you compared it for the same amount of time, this is with a comparison group of counties. For older youth, 25 and older, it did not go down. This is a shift in mortality, but it's just a lot of fluctuations. It's not significant. So there'll be more analyses. There should be a paper coming out on this. But it gives us hope that some of these programs that SAMHSA is implementing are making a difference. So we know that suicidal youth have pretty bad approaches to their own coping and getting help. They're more likely to hit other kids up who have similar problems, and that's not good advice for most of them. So the question is, whoops, let's get back to this. How to measure better help seeking, how to get these kids to actually get the right kind of help. And you have a lot of kids who get told about somebody who's suicidal, but they're asked to keep it a secret, don't tell anybody. So this is a big issue around homicide, suicide. If you can imagine all the school shootings, you want more kids talking about this and more people helping. So Anthony Pisani up at University of Rochester, building off of work that Matty Gould had done at Columbia, has developed with his team these measures that are publicly available. And these are being built into a sources of strength intervention. So they're looking at, ahead of time before the intervention, how does this look? Are youth willing to go get help from appropriate folks? So this will be some outcome data. And this actually taps into the system that the kids are in. And then just one more example here. Vince Silenzio and his team had National Science Foundation funding to look at how to measure social media space and density. And basically using a place where we know there's high-risk youth, LGBT youth who might go to the Trevor space. The Trevor Foundation has a hotline, and they built this safe place to network. And what they found was basically the less dense those kids' networks were, the more at risk they were for depression. I don't think they were powered to look at suicide, but it was kind of a proof of concept for how to look at this. So I don't have the specifics on the IRB pieces here, but tracking your social connections, of course, has lots of interesting implications. So the CRAN folks, the NIDA, NIAAA, and NCI folks have just funded a number of social media studies, which I hope we could learn from very quickly and borrow from. So I'm looking forward to seeing how those are fielded. And if you have any questions, please feel free to email me if you want any copies of this agenda. I still have extra copies, so I'll stop there. Thanks.